flaps in particular are a lot more tricky because you have taken that blood supply off and reconnected it, and in that process, it's gonna behave essentially like a newborn baby. So you have to watch out for everything about it. And that takes us to free flap physiology. There's multiple different things that go on when you disconnect the blood supply and take it somewhere else and you reconnect it. The first thing is systemic and local factors will affect it a fair bit, just like a newborn baby. If you've got a low temperature, they're gonna, shut down really quick. They're gonna get sick really fast. Hypothermia and temperature are probably the most important local factor for flaps. Now, for systemic factors, oxygenation, having a good blood pressure, all of that stuff is also important. Now, during flap transfer, the following occurs. One, there's ischemia, then the time between when we disconnect it and we reestablish flow. So that makes the flap a lot more sick, as it were, and the flap is sort of in shock for that first 24 to 48 hours, and so that ischemia really affects it. Now, there's loss of sympathetic innervation and autoregulation. This is key because the way that us as sort of animals will regulate our circulatory system has a lot to do with sympathetic innervation. So our ability to vasoconstrict when it's cold and vasodilate when it's hot, to retain and to expel heat, is affected by the flap. The flap can't do that by itself, and that's why the bear hugger is so important. And you see, I'll come back to this later on. Anaerobic metabolism. So again, your flap doesn't have enough oxygen usually during that period when it's ischemic, and even when you reestablish supply, it's not as strong. It's not able to absorb oxygen the same way as it would. And so because it's got anaerobic metabolism, then you've got increased lactate and superoxide radicals. Now, if at any point while this is going on, you've got a problem with your blood supply to the flap after the patient hits the ICU, then you're getting lots of lactate retained in the flap, lots of superoxide radicals, such that even if you take the flap back right away, some damage has already occurred. And that's why it's really important for us to monitor the flaps and identify when there's a problem so we can fix it. Because essentially, it's the same way when people say, if you get a stroke, the longer it takes for you to get revascularized, the more brain loss there is. It's the same thing with flaps. And of course, there's changes in blood viscosity and clotting going on. Ischemia time, just so we know also, flaps can be different things. They can be composed of just skin and subcutaneous tissue, or skin, subcutaneous tissue, and muzzle. And in some cases, it's just muzzle. Now, the reason I put up this slide so that you will know that muzzle flaps in particular are more critical. Because if you take them back, after 4 hours, you're probably not going to get a good result anymore. It's probably all going to die, even if you're able to reestablish flow. So ischemia time is the time that it takes for the cells to be irreversibly destroyed, essentially, for you to be unable to salvage the flap. Now, this typically depends on if it's warm, if you're able to maintain that flap in a warm or in a cold environment. The cold environment means that there's less metabolism going on, and so you can keep it on for longer. Now, this is also important for replants. We don't do as much of them here at UMC. So if you replant a finger also, thankfully that doesn't include muzzle, but if you reimplant a finger, essentially the same rules apply. So for warm ischemia, meaning that if you got muzzle that is not sitting in an ice bath like in the ICU, you got only 1 to 2 hours to reestablish flow. After that, if you reestablish flow, it's still not going to work. Now, if it's in a cold bath, so for example, if for some reason patient's being brought over from somewhere else to put in a cold bath, you got 4 hours to reestablish. If you go beyond that, it's not going to work. For most of our flaps, which are soft tissue, these are actually a little more forgiving. In a warm environment, you got 4 hours. And that's 4 hours from the time the problem occurred to the time you reestablish flow. Now, as you all know, even after you call us and tell us, oh, we think there's something going on, the resident comes in, we get out of bed, we get to the operating room, they open the set, we reconnect the blood supply. All of that alone is usually about 2 hours. So that means that for a warm ischemia on our flap, if you don't let us know within 2 hours of the problem, we're gonna have a lot of issues. Now, if it's cold, it's a different thing, up to 12 hours if you can maintain a cold bath. Now, flap monitoring, which is key. Now, there's several different things here. The timing is the first line that I've put in there. I said Q 15 minutes for the first hour, then 30 minutes for the second hour, then 1 hour for 24 to 48 hours, then 4 hours from day 3 to 5. We've simplified this. The patient comes to the ICU, we just say QR checks. That's pretty much it. And a lot of places, they actually make you follow this rule. We don't do that here because it's just a lot of work. But this is critical so that you know how important it is. In most places, even for up to 48 hours, they're checking the flaps every hour. And here, you have to go and check it. Now, what do you have to do every time you go by and check on that flap? Clinical assessment. So you got to look at the color, the cap refill, the temperature, the turgor, and the bleeding. We don't typically bother with checking the bleeding, but at least the top 4 you should check. Now, the color, is it pale or is it bluish? That's typically what we want to know. If it's pale, it means we have a problem with inflow or arterial supply to the flap. If it's bluish, it means the blood is staying in the flap and not draining out, meaning the vein is not working. So the bluish is a problem with outflow. The pale flap has a problem with inflow. Now, the capillary refill, is it faster than normal? Now, we all know how to do capillary refill on our fingers. It's the same thing for the flap. If you check, some patients are a little more difficult. If you're a dark-skinned patient, it's a little more difficult to identify cap refill and check the time. We don't want the cap refill to be too fast, because typically if it's too fast, it means it's engorged, it's bluish, and so it's, once you do a cap refill, and if it has no cap refill, then you have an arterial problem. So it's got to be in the sweet middle. Temperature, is the flap cold? Sometimes that's the first thing you can tell. But if you have a bear hugger on, even a flap that's going down is going to be warm. And since we put a bear hugger on all our flaps, it's something to think about. So just because it's warm doesn't mean it's fine if you have a bear hugger on it. But if you did not have a bear hugger on it and you're not warming the flap, and it should be similar to the temperature of the patient. If it's not, it means either the flap has a problem, or, is that a question? All right, if it's not warm, it means either the flap has a problem or the flap needs to be warmed. So the flap doesn't have a problem, but it can't maintain its own temperature because, like we discussed, the sympathetic innervation is gone. So we need to warm the flap. Turgor, is it soft? Most flaps should be soft. They should be similar to normal tissue. If all of a sudden it starts feeling hard and turgid and stuff, then you got a real problem going on. And then the bleeding, sometimes we will assess bleeding and poke the flap, try to see what sort of color comes out of it. But we don't typically ask our nurses to do that. Now, external Doppler is how we monitor the majority of our flaps, and that's an example of an external Doppler probe right there. Arterial signals are easy to hear. They're like a pulse, and they're triphasic. At the end of this presentation, I'll play some sounds for you so you can listen to what an arterial sound sounds like for the arterial supply of the flap. The venous signal sometimes may not be present. A lot of the time in our flap, we may not have a venous signal, and that's fine. If we do have a venous signal, it's really important, because when a flap goes down, whether it's a venous problem or an arterial problem, the vein will go down. So where, if you have a venous problem, your arterial signal may still be there, the vein will not be there. So it's critical not just to look at the external Doppler signals, but to examine the flap. Because as I pointed out, you may have an arterial signal in the flap where the vein's going down. So if you're not paying attention to the color of the flap, you won't pick that up until somebody else comes and says, that flap doesn't look normal. Okay? If you have a venous signal and it's gone, then you know you have a problem. But a lot of the time, we don't have venous signals. Now, internal Doppler is a buried Doppler, and that's the little box you see over there. It's the Coop Doppler, and that usually has a hum, a venous hum going on, and you don't need to check anything because it's right there at the bedside. It's making noise. But if the noise goes away, you really want to come check the flap and you want to call. Pulse oximetry for replanted limbs and fingers. A lot of the time, we just put a pulse ox on it, and it's not usually 99 when you start off because you just replanted it. Usually it's at 77 or whatever. But whatever number it's at, if it drops 20, 25, 30, then you know you got a problem coming up. So for replanted limbs, and every now and then we get a replant here as well, so it's important to think about them because they'll come to the ICU. Flap care. So this is also critical because I realize that our nurses sometimes have issues with different orders and so on and so forth. Usually most flaps have bed rest for 24 hours. So don't let the patient tell you they gotta go pee even if they don't have a Foley. Don't let them tell you they want to sit up or whatever. Usually they're bed rest for the first 24 hours, most of the time. I mean, they can sit up to eat if we feed them, but we don't even feed them for the first 24 hours anyway. So pretty much they just gotta lay there for 24 hours and just take a chill pill. Elevation, at all times the flap is in the limb. So if it's a replant, it's got to be elevated. If the flap's in the leg, got to be elevated. Phalloplasties, where we make new phalluses, we consider them as limbs. We treat them as limbs. So they have to be elevated. The elevation reduces swelling and reduces venous congestion. It allows the vein to drain out. The arterial pressure is pretty heavy, and so the artery will go into your flap even if it's elevated, if it's flat. But if your flap is flat or pointing down, the vein won't be able to work out, and that's really critical. The head pressure is usually good for the artery, but the vein needs the elevation to drain. Dressing changes help with wound healing, and also when you're changing the dressings, you can also check on the flap. So it's important to do dressing changes. Warming bear hugger use, that's something that ideally we should be able to also do on the floor here, but we're not able to at UNC, so hopefully we get to a point where we can do that here. Positioning, you want to avoid pressure on the pedicle, which is the blood supplies that are connected, that are supplying the flap. And usually we'll point that out to you if you ask when we sign the patient out, where the blood supply comes in. You don't want to drop anything on there. You don't want to put like your, splint on it. You don't want to, you don't want the patient putting it down. And I'll show you a few pictures of that as well. You have to be cautious. So sometimes we connect it right next to somebody's ear. We don't want the patient sleeping on that side. We want them to sleep on the other side. And then it's your role, since you're there at the bedside, to make sure that that doesn't happen. Because the patient's out of it. They just had surgery for 24 hours, 12 hours, whatever. And so they're not going to do it themselves. You need to check the drains for volume and character of output, because you can get a hematoma, and the hematoma will compress the vein. That's bleeding on the inside. So usually we have a drain in there. You want to keep an eye on it. If all of a sudden the output goes up, there's a ton of clots, you want to call somebody. You want to look for new onset swelling suggestive of bleeding. Medications and oral intake. Usually we'll put our patients on aspirin. We'll put our patients on heparin. Heparin also prevents DVT, because now we put the patient in a bed for 24 hours. So not only does it improve the flow to the flap, but it also reduces the chance that the patient gets a clot in their legs. We may give us drip if we take the patient back for so if a flap has had a problem, we take it back. By the time we bring the patient back, we give the patient a drip. Or in replants, essentially all my replants, I will put them on a drip for about 5 days. So these are medications that you have to understand. If the patient is bleeding a little bit and it's not related to the flap, we may hold a heparin. Patients are NPO for the first 24 hours. Usually you want to avoid coffee and nicotine when they start drinking and eating. So if the patient just all of a sudden says, oh, I always have black coffee, I'd like you to make me some black coffee, that's what I want, you should tell them, no, let me check with your doctor first, because usually that increases the chance of spasm. Arteries tend to spasm a fair bit if you have nicotine, especially if they're really small arteries. This is probably a lot more important for small replants like finger replants than it is for big flaps. But even big flaps, patient driving home on day 4, sometimes their partner smokes in the car the whole time on the 4-hour trip, the flap will have a problem. So it's a real thing. IV fluids. Now, usually you want to aim for a 0 or slightly positive balance. We never want to overhydrate our patients. So if your bed commander starts all of a sudden ordering tons of boluses or something, you might just nudge them and say, did you check with the primary team? Because I know they don't usually like to give this much fluids. Usually you don't want the patient to be hypotensive. So if they're hypertensive, you may want to, or if they're not making urine, you may want to catch up with that. But if there's no good reason to give the patient a lot of fluids, you got to back off a little bit, okay? Fluid overload just leads to more swelling. They may have a high BP that is higher than what is normal, and then all the small vessels start to bleed that shouldn't be bleeding normally. Of course, we don't want the patient's BP to be too low, and then they can't perfuse the flap. So a happy medium is ideal. More swelling will worsen venous congestion. We typically try to avoid pressors in this patient, and of course, always call us if you think the patient needs pressors. Hopefully, before the patient needs pressors, we've already been called about the hypertension. But in general, pressors will increase vasospasm of the vessels going in our flap, and so we typically want to avoid that. If the patient is hypertensive, it can lead to thrombosis, so we don't want them hypertensive. We typically want to fluid resuscitate them. Usually we use albumin and all of that stuff, and identify why that's going on as well. So these are examples of pictures of different flaps that have problems. If you see that flap on the left side, the breast flap, she has a right breast and a left breast. I don't know if you can tell, but that left breast is a little more blue than the right breast. And this is typically when we want you to call us. We don't want you to call us when it's so blue that everybody can see. We want you to call us when it looks just a little different than where you started from. because that's usually when it starts. As you can see in the penis on the left side, that's definitely blue on that side compared to one side. Anyone can see that. So that's sort of a little late in the game when that happens. Usually you want to pick it up when it's very subtle. Okay, the change in color. And sometimes it's nothing that we need to be bothered about. We'll just say, you know, make sure the bear hugger is on. We'll keep an eye on it and it'll get better on its own. Like in this patient, I think she was fine. But usually we want to know when it's like this. We don't want to wait too long. Now on the other side, you can see the flap to that patient's leg. You can see the tip of it is blue. So we want to know that. You know, we don't want to find out in the morning. We want you to let us know when you notice that, you know, an edge of it all of a sudden looks different than the rest of the flap. Because maybe we just need to take out a few sutures in that location. Maybe we need to check to make sure the vein's working. So you want to look out. Venous compromise forms about 70% of failures with the flap. Arterial problems only 30%. So frankly, if you really just look for the vein, 7 times out of 10 you'll be correct. So that's what you really, really need to look for. So of course you can see, anybody can see that that patient's flap is venous. But that's not when I want you to call us. I want you to call us when it looks like that. So rapid identification and intervention is key to avoid disaster, like I discussed. A lot of these flaps, you have only 4 hours because it's warm ischemia, right? It's not in a cold bath, it's on the patient. So if you don't reestablish flow within 4 hours, some of the flap begins to die, if not all of it. And as we discussed, venous compromise is typically the most common cause. Arterial thrombosis may also occur, but if exam findings change, if it doesn't look like it looked like when the patient came from the ICU, then you should call and ask your doctor there to have a look at it. And they should get in touch with our residents and somebody should come get us, okay? Now this is an example of a flap that has an arterial problem. As you can see, the patient's face is normal and red, but the flap looks all white. So that's an arterial problem as compared to a venous problem. All right, now other issues. Like I pointed out, the gentleman on the right side has the blood supply to his flap on his head. Now this is an example of a muzzle flap, it's just got a skin graft on it. So this kind of flap, you know, if it's 2 hours since it went down, you take it back, you're not gonna save it, it's gonna die. But what I'm trying to point out here is that the blood supply comes in right there by his ear. So this sort of guy, if he's, you know, in the ICU, and this is a patient of mine from last year or 2 years ago, he can't lay on that side. So while he's asleep, he needs us to help him, to prevent him from laying on that side. Because if he sleeps on that side and that, you know, that area gets pressure on the pillow, then he's not going to get any blood supply to his flap, and then it's going to clot and it's going to go down. So all of these things are extra sort of little minutiae. You know, our patients are not multi-organ failure patients. They're essentially usually reasonably healthy patients that can tolerate surgery, but we have to watch all these little things. And I understand that the way critical care nursing works is that you look for all, you know, the pulmonary problem, the acute renal failure and all this stuff. That's not what's going on with most of our patients. It's these little things. Where does the blood supply come in? Is the flap warm? You know, is the flap color changing? That's what you really need to follow with our patients. The patient on the left-hand side, the blood supply, as you can see, that's a very interesting thing. We're elevating the foot, but not only are we elevating the foot, we're not elevating the foot by putting the pillow on the heel. We're putting the pillow under the knee. And the reason for that is that the blood supply to this patient's flap is right there in the mid-leg. So we sort of need the leg cantilevered in the air like so that we get elevation, but we avoid compression to the blood supply. So our flaps are all like that. So you gotta, it's hard. You weren't there when the flap was done. You were not in the operating room. But you have to have that understanding and ask, you know, where does the blood supply come in? Why exactly is it in this direction? Where's it, you know, so why do you, so, I mean, this particular patient had multiple nurses on the floor just change the elevation. And we had to keep doing it over like a 4-day period. So this is something that you have to understand, that the blood supply comes in from an area. You have to think about that. You have to think about the elevation. You have to think about all of that when you position and when you move the patient, when you do whatever you got to do. All right, so this is what people think about when they think about plastic surgeons. And, but this is not what we do, at least here. This is more like what we do. And to be able to do this, we need you guys to work with us and to help us, you know, make these patients have a good result, go home, have a better life, And it's just the little things that happen every time in an hour, every hour when you go check the flap, that make a difference between whether or not we're able to achieve these results or we're not able to achieve these results. Thank you. I'm happy to take any questions if there's anybody out there.
I have a question.
Yes.
So for example, the patient with the leg where the blood supply was going for
Correct.
that picture.
Correct.
When you bring the patient back from the operating room, you're telling the nurse that's accepting that patient, this is where the blood supply goes.
Yes.
Do you guys have anything in place for like a diagram that comes and you're able to circle it and show it and post that in the room so that, because again, we switch out every 12 hours, right?
So we don't typically have that picture and sometimes have to describe. What we typically ask for is that when we describe it to you, that when you sign out,
Of course.
you do a detailed description to the next person. And I understand that doesn't always happen.
Well, it's just like the telephone game,
Right.
If I'm going to tell you
Less
and you,
information.
it's going to change by the third
Less
person.
information
So
propagates.
sometimes it's not. A lot of times it's not our people; it's our processes, right? So if we could, that may be something that we should.
Sometimes we'll take a picture, and then the doctors will share with each other, but they don't typically share with you guys. And it's something to think about, especially when we get these more tricky ones.
So I'm thinking about it so when we have burn dressings, we do a lot of skin grafting. So it's the same thing. They're very delicate.